right, so I am with Dr. Joe DuBose. He's going to be talking about his Quickshot. Do patients with minimal blunt thoracic aortic injury require Tvar? Thank you, Dr. DuBose, for being with us. So my first question is really, how did you come up with the idea and where did it kind of stem from?
You know, I think a lot of it was just watching patterns in blunt thoracic aortic injury management. As clearly, Tvar has taken over the realm. It's now the standard of care. Greater than 90% of these injuries, as opposed to 2 decades ago, are dealt with Tvar. But as with any exciting technology that's relatively easy to use for the appropriately trained people, there's a tendency to potentially overutilize it. And there's enough gray area in blunt thoracic aortic injury grading and not enough understanding about the natural history of those relative grades that I would contend, I think based upon this study is not the only one that's kind of moving in this direction, that for some of those minor grade injuries that currently a lot of vascular surgeons treat with Tbar, that maybe they don't need to be treated with Tbar and that we're kind of over treating.
Good. So that really takes us into my next question about, give us a brief synopsis of your paper.
So essentially what we did, the Aortic Trauma Foundation is a nonprofit organization that has a prospective registry that captures a degree of granularity for blunt thoracic aortic injury that really has been unprecedented in the trauma world. And this was accomplished through a partnership with the ATF and AAST. And so the registry is run through those organizations, and it really gives us a nice data set to look at with some granularity across a multi-center platform at what's going on with the management and outcomes of blunt thoracic aortic injury. So we took that data, which is about over 150 patients currently, but we utilized the data set that gave us over 100 minimal aortic injuries, meaning the Society for Vascular Surgery grade 1 as intimal injuries or grade 2 intramural hematomas, and we looked at the subsequent outcomes. And essentially what we found was that there's no difference whether you're treated with Tvar or not and for these patients, and that the complication rates were higher in the Tvar group, but only as related to the Tvar specific complications that can occur. So if we're treating these minor aortic injuries with this entity of Tvar, and we're accruing complications that we wouldn't otherwise be occurring in injuries that would otherwise heal, are we really doing the patient service? And that's kind of the whole nutshell of our study.
Just as a brief aside, did you look at hospital length of stay at all? Was that affected? We
did, and it was not. You know, you would think that maybe some of those medical managed patients would be just left in ICU longer to see what the natural history is, but it really didn't at those grades of injury influence any outcomes.
Okay. What do you think would surprise people most about your findings or the study itself?
You know, I think there's a disconnect between, clearly Tvar is the standard of care for blunt thoracic aortic injuries. The majority of trauma surgeons certainly don't do that procedure. They care, but they are instrumental in caring for the patient as a whole and all the other injuries. But when you as a trauma surgeon consult an interventional radiologist or vascular surgeon, they see a lesion and they treat that lesion. They want abnormal to look normal. And without having any context of what the healing process of that abnormal to get back to normal might otherwise be. Because there's great literature out there that shows that a lot of these grade 1 and 2 injuries, or the majority, will heal within 8 weeks. So if you have a little patience and their blood pressure can be managed to an appropriate range, then you really don't need to do Tvar, in my opinion.
Okay. That really kind of segues into what do you hope people take away from this? And you've touched on vascular surgeons, but as pure trauma surgeons, not this crossover between vascular and trauma, what should the trauma surgeon themselves take away from this?
I think just be a better partner and more discerning about how you manage this specific injury in the context of what almost universally is a polytrauma injured patient. I think we as a community have a better opportunity to be more granular in our description of blunt thoracic aortic injuries. If you look at the AAST grading injury scale, if you have a blunt thoracic aortic injury, it doesn't matter what type, what it looks like. It could be minor, it could be severe. You get an AIS of 4. And by proxy, you end up having an ISS if you have any other injury of greater than 20. So we're grouping all these aortic injuries into one context. That's kind of the way we're trained as trauma surgeons. And unfortunately, I don't think that the answer is that simple. They're not all the same. And we can probably do more harm than good by treating the ones that don't need to be treated.
Awesome. Do you have any follow-up studies planned? Anything else you're going to look into, or?
Yeah, we certainly do. This AAST Aortic Trauma Foundation partnership is a fantastic one that I think is going to give us a lot more answers. It continues to grow in terms of volume of patients contributed. We'll be able to look with a lot more granularity at this specific subset of patients. And importantly, the follow-up portion of this study, which was designed from the beginning, continues to grow. So my hope is in the next couple of years, we'll be able to show that those patients that didn't get treated had resolution of their injuries, just as the other studies have already shown.
Perfect. Awesome. Thank you for your time.
Yes, ma'am. Happy to do it.
All right.